I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's? The current fee-for-service healthcare system rations out care based on the patient's ability to pay. I believe this is unethical. It is criminal. 95% of the country is still functioning on this fee-for-service model. I believe everyone should be treated the same. Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel and Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Tonight's topic is women's mental health. My co-host and moderator of the chat is Dr. Dan McCarter. Welcome, Dr. Dan. How are you doing tonight?
Hey, Faisal, it's great to be here with you. This is a timely topic for the holiday season.
Yes, it is. I am so thrilled to have our guest on joining us tonight. When we just, in general, when we talk about mental health and the state of affairs in the country with mental health for everyone, even including our children, the impact with all the distance learning and everything that has happened because of the pandemic. And then even recently with the news that we're hearing, all the anxiety that's coming with the news that's coming from around the world about another variant, I think it is a timely topic. So without further ado, let us welcome our guest for the evening, Dr. Sipra Laddha. Dr. Laddha, welcome.
Hi, I'm happy to be here.
Thank you so much for joining us tonight. I'd like to start off by talking about your life journey. Most of our audience are residents, they're physicians. We love hearing stories about why you ended up pursuing your path in life.
Yeah, so I'll start off from kind of when I was a kid. Both of my parents are physicians. Medicine was what I knew. It was what I grew up around, and my parents were very passionate about their trade, and I knew that I wanted to be passionate about whatever it is that I did. And so kind of did the typical pre-med. I actually graduated a year early and went to med school a year early because I was so excited to get in there and help people. And, then I got to medical school and did a whole bunch of rotations. I was very interested in neurology. I had done a lot of research in neurology, and I somehow drew the short end of the straw. And I got to last pick out of my entire class. I think there were 135 of us. I was 132 to pick my rotations and my schedule and things like that. So I didn't do my neuro rotation until fourth year, the month before we had to apply for specialization. So I went through, all my rotations, just liking some things, not liking other things. And I found with all the extra time that I had, all the electives, I was taking psych rotations. I did emergency psychiatry, which I thought was really interesting. I did a little bit of perinatal psychiatry, but thinking I'm going to be a neurologist. That's the plan. And then I did my neuro rotation a month before I was supposed to apply to residency. And I was like, wow, I don't want to do this. I thought it was a great field. I love the people that I worked with, but it's what was it that really motivated me? And I kind of just looked at my rotations and the places that I had the most fun, and the places that I was naturally drawn to was psychiatry. I think that disease process is really interesting. But what I was finding is that the way diseases affected people and dynamics between patients and caregivers, patients and their families, patients and their society, was just wildly interesting. And so I kind of had an answer. Called my parents and I said, I think I'm going to do psychiatry. And they were like, okay, I think that sounds okay. But what is psychiatry? They especially coming from India, there's not a ton of awareness around mental health and what the actual field is about. So then I went off to Emory and I did my residency there, really enjoyed it, got to see a lot of different pathology, a lot of different settings. So, inpatient, outpatient, private hospitals, county hospitals, and had a great time. My last year of residency, I became unexpectedly pregnant with twins, just as I was applying to child and adolescent fellowship. And I remember when I found out I was pregnant, I was like, I was due the month that I would start fellowship, and I was like, I can swing it. I'll figure it out. I'll do it. And then we found out it was twins, and I was like, I don't think I'm swinging anything. I think I maybe just need to give this some space in my life. And so I did a chief year. I was at the VA really helping to kind of fill gaps in care. And I also did perinatal specialization under Toby Goldsmith, who runs the perinatal clinic at Emory. And it was a really interesting time in my life because here I was with this high-risk pregnancy. I had monodi twins. They were sharing a placenta, getting regular care, you know, sometimes weekly ultrasounds, twice weekly ultrasounds. I was working in the perinatal psychiatry clinic and kind of looking around and being like, wow, this is, you know, really interesting field. Didn't learn anything about it until my 4th year of residency. And it's highly specialized and highly needed. We would have patients that would sit on the waiting list pretty much their entire pregnancy. And so they would, you know, try to book an appointment when they were a couple of weeks pregnant or when someone referred them to care. And then we were seeing them in the clinic sometimes 2, 3, 4, 5 months after they delivered. And so realized immediately there's a huge gap in care there. There's a lot of difficulty with availability. And then also just going through my process, you know, my OBGYNs were wonderful. They did exactly what I'd hoped that they had done. My perinatal specialist, they got my twins here happy and healthy at 36 weeks and 3 days. But I probably had 45 touch points with them before I delivered. And there was no single screening at all for perinatal mood disorder. You know, they did everything they were supposed to, but I started noticing like, there really isn't much support for this. There's no screening. There is no way to kind of pick up in a routine and systematic way what else might be going on that would be affecting the pregnancy in metrics that aren't, you know, normally measured right now. And we also know that women who are carrying twin gestations or multiple higher order gestations are 3 to 4 times more likely to develop perinatal and peripartum mood disorders. And so it kind of started my journey with perinatal psychiatry and really women's mental health, noticing that there's a lot of work to be done.
Wow.
And so I had my twins. I graduated from residency. Right out of residency, I started my own women's mental health private practice. I also worked at the VA for about 7 years in women's mental health there, and also in plugging holes and kind of figuring out systems issues. And just recently, about 6 months ago, I and a child and adolescent psychiatrist, Dr. Rathi, started Thriving Lane, which is a women's mental health focused telemedicine platform that is currently in Florida and Georgia and quickly expanding to other states, which is focused on kind of making sustainable solutions for women's mental health.
Gosh, what an incredible story. I love this. I love these stories. I mean, they're always wonderful stories about how people end up. I was wondering the story behind getting Thriving Lane started and even specializing and focusing on women's health.
Mm-hmm.
I'd like to talk a little bit more about why you feel women need a specialized approach towards mental health.
Yeah, and you know, I'll answer that kind of in 2 veins. One is that why Thriving Lane and why, you know, deciding that we needed this solution in women's mental health was because I was getting to the point where, you know, and I live in a big city. There's a lot of psychiatrists around me. There's actually way more access to care here than there is in most parts of the U.S. And I was getting to a point where I was squeezing people in during lunch breaks and before work and after work and on weekends sometimes, and kind of sat back, especially during the pandemic. The numbers, the referrals were going up, and started thinking like, what can we do to really have a sustainable solution? Just having one more practitioner see one more patient a couple of times a week, that's not a sustainable solution. And so we realized that there is a big gap in the workforce around this, right? So mental health is kind of interesting in that we have therapists, LCSWs, psychologists, LMHCs, people who deliver therapy. And then we have psychiatrists who are physicians and have been trained in medical model. And then we have the other subset of physicians and practitioners that are seeing these patients, which are OBGYNs, primary care doctors, family medicine doctors. And there is not good communication between the three at all. Medical people are focused on medical, therapy people are focused on therapy. Psychiatrists are somewhere in between, but often just kind of overloaded and trying to catch balls as they drop.
Yeah.
And the therapists are really missing the medical piece, which I think is so important in women, especially in women. There's multiple transitions that are uniquely female, whether that's puberty, pregnancy, all the things that happen before and after pregnancy, miscarriage, infant loss, perimenopause, and then the social changes that go along those times as well. And so, especially for women, because there are so many transition points, unlike in men, especially for women, because there are so many transition points that are biologically mediated. It
Yeah.
is really important to kind of have that marriage of medicine and psychology, and kind of get women's mental health as a priority.
Wow. I'd like to zoom out for a moment,
Mhm.
and you touched on this, like where you live, there's plenty of psychiatrists. The access is there, but what you found, I mean, you've been able to address at least the access issue for those people who are outside of these metropolitan areas with a telehealth model.
Mhm.
So I'd like to talk a little bit about how you've developed that, but also, you know, so many psychological illnesses in general go undiagnosed for years.
Yeah.
So I'd like to talk about that as well. How you're able to help increase access with telehealth, and have you seen an improvement? Are you seeing a difference
Mhm.
with conditions being diagnosed thanks to the use of technology?
Absolutely. Yeah. So I think that to answer your multiple questions,
I know, like always, like it's like rapid.
yeah, so to answer your multiple questions, I think telehealth is an incredibly powerful tool, especially in psychiatry. I think that because 95% of the exam can really be done via video, there aren't a lot of barriers. There's not a lot of reasons why telehealth would not be a good substitute, as opposed to potentially cardiology and some other fields of medicine. But I think also, women tend to, I'm making a generalization, but they tend to be kind of the underpinnings of society. They are supporting older parents and adults. They're supporting sometimes young children, sometimes supporting spouses. They're also 50% of the workforce. And so what we typically find is that women come in crisis. They don't come in because they're doing any kind of preventative mental health. They don't typically come in when things are kind of just bad. They typically come in when someone has caught them in crisis, when a family member, a friend, a primary care doctor has said, like, stop, you need to go and do this. And typically they will call and cancel the appointment because someone has gotten sick, someone has needed something. And it is quite an inconvenience, to wait on a waiting list and to drive somewhere in the middle of the day and to sit in a waiting room and have a mental health appointment. And so this has made it much more accessible for women to do all the things that they're doing, but also attend to their mental health. And, also via telemedicine, I think we've been able to incorporate a large number of modalities that's not sometimes easily done in the office. When you go to a psychiatrist's office, there's a psychiatry approach. When you go to a therapist's office, there's a therapy approach. When you go to a yoga instructor's office, there's a yoga approach. And I think what we've really been able to do at Thriving Lane is bring all of that together. So all of our practitioners are knowledgeable about the medical piece, even the people that aren't prescribing medication, but they kind of understand that piece of it. All of our providers can provide holistic interventions, including breath work and breathing and mindfulness and meditation. All of our providers, in this space together in one location, can provide an end-to-end solution for women's mental health, which is incredibly powerful and very different from driving all around town to try to get different facets of mental health addressed.
I would, we notice similarly with our, we do primary care, specifically with geriatrics, elderly care,
Right.
and we had to make a switch. We have a high touch model, in person model, and because of the pandemic, we had to switch to a primarily virtual model. Now we're kind of in, somewhere in between, depending on each patient. But like some of we notice a lot of similar. The patients have had similar experiences. The convenience of being able to access not only your doctor but really anyone from the primary care delivery team.
Mhm.
Our average patient's over 70 years old, So you can imagine transportation is a huge issue for our patient
Yeah.
population. We have a center in St. Louis where over 90% of the patients rely on us for transportation services. It's huge. So being able to offer the telehealth either in video or even because we don't bill, we were able to provide a lot of medical care just by phone as well.
Mhm.
And so, sorry.
Well, no, I was just going to ask. I mean, have you? I'm sure you've probably heard of the impact model from the University of Washington, where they use the behavioral healthcare providers along with primary care to do some of the prescribing, and then have the psychiatrist doing the remote coordination. And I just wonder, is your model, because you say they come in crisis, but I could imagine that either the pediatrician or the obstetrician might see that it's a crisis, maybe even before the patient does. Do you have any kind of coordination going on in those models?
Yep, and we are actively working on our coordination directly with primary care, again, to not get people in crisis care. And I think that there's a lot of learned helplessness in medicine, right? We don't have great mental health solutions. We don't have great access. And so a lot of the times, primary care doctors are sitting in their visits trying to figure out how to solve multiple problems at once, and then a mental health problem on top of that. There's just a lot of difficulty. And so the models that we've seen work best are when there is psych backup, psych close by. I think it really seems to empower a lot of primary care doctors too to stretch their ability with the psychiatric patient if they know that there's a psychiatrist just a phone call away that they can call and curbside or even get in for quick care if they suddenly are outside of their comfort zone. And so we're actively working to promote that as well.
Yeah, I mean that obviously is just such an important, having that coordination, and when the crisis occurs to be able to do that. So I think, I know we've, in some of our markets we do the telepsych, and that just makes such a huge difference to actually be able to bring the psychiatrist to the patient,
Yeah.
And also help the primary care, because as you say, as the primary care, as with the primary care physician being involved in that care, they learn more, and we're able to raise our levels of skill and practice as well. So
Mhm.
very interesting.
And I want to put in a plug for one more thing. I don't know. I hope it's okay with the time, but in psychiatry, who is going to need care at some point, especially during a time of transition, actually is quite predictable. So if there is a first degree family member who has depression, anxiety, some other mood disorder, that patient is already at high risk, 50% more likely than the general population. You take two family members and we know that then at a time of stress or at a time of transition, a time of biological transition, that person's risk of developing something that is going to be problematic is so incredibly high. Kind of putting in a plug for preventative care, which is, the basis of primary care, that we can do that in psychiatry too. That's a huge piece that's missing. And I think with active collaboration with primary care doctors and even kind of thinking and talking about this, when people fill out their history and they're doing fine and they're feeling well, but they write like, yeah, my mom had depression, my brother had really bad anxiety, like that person kind of almost needs to be in a separate funnel where, they have very quick, easy mental health access, because the likelihood of something coming up is pretty high and the likelihood of them needing services is pretty high. And maybe there's even, a preventative care track where coping skills, some preliminary CBT, tools around insight can be delivered before they're needing it. So not just not crisis care, but preventative care in mental health, and especially women's mental health, I think is a huge field that is ripe for disruption.
Too much of medicine is reactive.
Mhm.
It waits until there's a symptom or there's there's a complaint from the patient or the patient's family or friends, loved ones. I'd like to talk about some of the stigma surrounding not only mental health alone, but really in particular with women's mental health. What you have seen with, especially now with the pandemic, there's a lot of stigma with even coming earlier, coming sooner, that, hey, I've got something going on.
Mhm. Yeah, I think that there's a lot of stigma with mental health. I think that there is a lot of narrative that is generated, often in families, in our society, that mental health is something that needs to be kind of just, you need to pull yourself up by your bootstraps and power through, and putting one foot in front of the other is just the way to do things. And there's some truth in that, right? Putting one foot in front of the other is always a great way to keep moving forward. But it really kind of ignores the fact that there is prevention to be had, that there's treatment to be had. And I think that a lot of that is also seeped in learned helplessness, which, if people don't really feel like there's effective treatment, and a lot of people don't, then there's nothing to do about it. And if there's nothing to do about it, then there's no reason to think about it or talk about it or really pay any attention to it. So I think that that's one part of it. I think that there's a lot of confusion around what mental health treatment actually looks like, right? Most people, when they think about psychiatry or psychology, they're like, oh, are you going to read my mind? Are you going to, do something? And there just isn't that much awareness and education. And I think that's where stigma really thrives, when you have something that negatively affects people, that can be debilitating, where people don't feel like there's good solutions and there's not good knowledge around illness or solutions. I mean, that's breeding ground for stigma, and so stigma continues to survive. And I think especially for women during transition, there's a lot of what I call like reverse normalization, which is not a positive thing, right? Having a baby is difficult, and so there is a lot of expectations on new moms that, yeah, this is what it is. You just have to white knuckle your way through it. So you didn't sleep, so you're crying all the time, so you're super anxious. That's part of it. Like, we all do it. Move on. Or menopause. Menopause is incredibly difficult for a lot of women. There's a lot of mood shifts that can be triggered from menopause. There's a lot of depressive symptoms and disorders and things like that can be triggered from that. But our narrative around that is like, yep, everyone goes through it. Like, sorry that it's uncomfortable. We don't really want to hear about it. Like, next. And so that's something that definitely needs to shift, and I think will shift, and is starting to shift with more education and awareness around it. And this idea, especially in pregnancy and postpartum, around the 4th trimester, and around that being a particularly vulnerable time, where it's not just healthy baby, we're done, let's move on, right? Let's kind of now focus on other things, where that time is an incredibly vulnerable time, where we do need to be paying attention to mom and baby and that dyad, and how that dynamic is going, and mom's mental health and mom's physical health, and how the whole family is handling it. So,
wow, thank you so much. I would like to take a quick commercial break for just 20 seconds, and then come back and talk a little bit about some of the differences between men and women with some specific conditions.
Mhm.
So let's take a quick 20-second break, and then we'll come and wrap up with a couple specific condition questions.
Sounds great.
ChenMed honors seniors with affordable, top-of-the-line care, and we're expanding. We're opening 25 new centers this year, including centers in 2 new cities, Houston and Detroit. Join us as we bring better healthcare to more seniors. Head to chenmed.com/physicians for more information.
And we're back. It was just 20 seconds. It's always just 20 seconds. So I'd like to talk about some of the differences between men and women with some specific conditions here. If we can start with depression.
Yeah, so sometimes depression in all people can look a little bit differently. One of the biggest differences that I see is often in women, depression is marked by crying, feeling down, having lots of sadness, having what I call like hyperreactivity or overreactivity to stressors, so that there's a larger than anticipated reaction to some things that might be going on in life that are stressful. And when men come in and present as depressed, sometimes the questions I ask are a little bit different. not necessarily crying spells, although men can have crying spells as well, but more around lack of motivation, apathy. Apathy is a huge one, and apathy is not something that is easily recognized unless someone is insightful or someone else has noticed. But it's always interesting, especially with men, that'll be one of the first presenting symptoms that we'll see. There's a lot of apathy. There's not necessarily sadness, but just this kind of disconnection to the things that they're normally used to feeling, quite passionate about. So that would be one difference that I typically see between men and women.
Wow. And do you see this with anxiety, like things like anxiety and bipolar disorder as well?
Yeah. So anxiety, often with women, I'll see like agitation, sometimes panic attacks, a lot of feeling anxious, a lot of being able to describe often what the trigger was for the anxiety, how it felt. Men often, the presenting symptom is not anxiety, like something happened and then I started feeling so anxious. It's actually irritability. So irritability is kind of a big thing to look out for in men in terms of symptomatology for anxiety and depression. Just they wake up irritable. They're easily snapping. They're not necessarily running around with their heart racing or able to tell you specifically what their worries are, but they're just feeling really irritable and they're reactive. So those would be some differences. And even in bipolar disorder, and for men and women, for bipolar disorder tends to present a lot earlier for men. Men tend to present with manic episodes first, as opposed to women. Bipolar disorder tends to happen a little bit later. So rather than in the teens and in the 20s, typically we're seeing late 20s and 30s, which is also often coincides with reproductive years. And for women, we usually actually see depressive episodes first. Sometimes a woman might have 5, 6, 7 depressive episodes before having her first manic episode, potentially in her 30s, sometimes after the birth of a baby. So there's definitely a difference in the presentation, not only in the years, but also how it presents, with men presenting with mania and women presenting with depression first, often for a prolonged period of time.
Wow. This is great. I can't help but just think about myself and my wife as she's speaking. I'm thinking, oh boy, I definitely. So one of the best things about having a podcast is we get to connect with people and ask them all the questions. I like. I don't know if this is for the podcast or more for me, Dr. Dan. While we're here, if we have some time, I'd like to talk a little bit more about some more conditions. If we could talk about eating disorders.
Yeah. So eating disorders tend to disproportionately affect women, like fourfold. But that's also not to say that eating disorders do affect boys. They do affect men, largely overlooked. A number of teenagers, young adults, young men pass away from eating disorders every year. Eating disorders can be incredibly dangerous. They have an incredibly high mortality rate. And eating disorders, body image issues, which is what they're based on. When I think about eating disorders, I think about family dynamics. I think about anxiety. I think about control. I think about OCPD personality traits and anorexia nervosa, bulimia. All of that is also based on body image. And body image for girls often develops as teenagers, as they're starting to go through puberty. And then you have kind of the perfect storm of things that come together and eating disorder is born. But that is also, another area for intervention. We don't proactively do anything with body image in this day and age. We kind of have teen girls that are out there that are exposed to all sorts of different things, some things positive, a lot of things negative, and just kind of hope that it lands correctly. And that's not terribly effective, right? We're finding out that that's not terribly effective. And so, body image is something that we can be affecting earlier. The way that we think about body image, the way that we proactively talk about it, the way that it's treated in families, in primary care offices, in other places as well, I think is an area that is also, as I like to say, ripe for disruption.
It definitely is, and I can see why you've pursued Thriving Lane and the work that you're doing there. I would love to see if we could do some work with you in some of the cities
Mhm,
that we're licensed in together. That would be wonderful to
mhm.
do a pilot specifically for women's mental health in the geriatric population.
Yeah, bringing it to the geriatric population, I think that women in their geri years are quite complex, and um, there is a lot overlooked there as well. There are actually a lot of kind of predictable changes that happen, whether that is loss of health, whether that is kind of disconnection from their normal abilities, whether that's their employment or just who they're used to being in their family, right? They serve a certain role for a certain number of years, and then there's displacement at some point. There can be isolation. There can be a lot of really predictable changes and transitions that happen. And what we know is that those are determinants of medical health as well. And I think in the geriatric population, especially because of kind of the treatment of mental health over the years and how they grew up thinking about mental health, that often there's some resistance to the idea of seeing a therapist or seeing a psychiatrist or having any kind of talk therapy. And there is a lot of, well, this is just life. Life just is like this. But the whole idea with therapy is that no matter what is going on in life, whether that is declining health, the loss of a spouse, difficulty with family, social isolation, that the way that you can feel about that is different, and that your experience is different, and that regardless of the events that are going on, mental health can still be improved. And so I've actually, this is a big statement, but I'll make it anyway. I've never met a geriatric patient who has done therapy and done psychiatry and said that wasn't helpful and it wasn't effective. It's kind of, for a lot of my older patients, the thing that they never knew that they needed. And we're seeing a lot of really great outcomes. So
Wonderful. Well, Dr. Laddha, thank you so much for joining us this evening. This was so informative. Dr. Dan, this was just fabulous. Got to ask her about specific conditions and we got to tease things out. I mean, I was a little bit anxious about having an episode on women's mental health. The first thing my wife said, she said, do you have a female doctor joining or a male doctor? So
Yeah,
thank you so
no,
much. I mean, you really made it. Yeah.
I mean, it is so important. And I mean, I think the saying in my house is similar to a lot of people that if mama's not happy, nobody's happy. And I think in society that's true. If women aren't thriving, society's not thriving. So this is probably something we really need to pay a lot of attention to.
agreed. Thank you for having me.
This was wonderful. And to our audience, for more information about tonight's topic, as well as to explore career opportunities with ChenMed, please visit chenmed.com. We believe access to primary care is a right, not a privilege.